name is Erin, and on behalf of the Pennsylvania, Virginia, and West Virginia MGMAs, I'm pleased to welcome you to our collaborative webinar today. Thank you for joining us. I'm hopeful that we'll have lots more of our friends joining us in just a minute. I'm happy to welcome Renee Russell. Renee serves as a consultant for total medical compliance. Renee has completed her dental assistance course in 1988 and earned an associate degree in dental hygiene from Florence Darlington Technical College in 1992. She graduated with a Bachelor of Health Science degree from the Medical University of South Carolina in 2006. Renee is a member of the South Carolina Dental Hygiene Association, the American Dental Hygiene Association, and the Organization for Safety and Asepsis Procedures. Renee's experience both as a chairside dental assistant and a hygienist helps her to fully understand the needs of dental team members in achieving HIPAA compliance, OSHA compliance, and infection control. She served as a speaker nationwide on OSHA, infection control, and HIPAA. Renee has spoken with us on this series a few years ago, long before COVID and things, but we are happy to have her back. It's a pleasure to have her. She's coming to us from South Carolina today, so we are very pleased to have her. So let's welcome Renee.
And thank you, Erin. I appreciate that, and I thank you for having me back. And welcome everybody to Friday, yay, right? And Friday the 13th, no less. But just in case anybody is worried about it being the 13th in the webinar, 13 has always been my favorite number and still is my favorite number. So don't worry about the Friday the 13th thing, because it's all good in Renee's world today. So again, thank you for having me, and we're going to spend a little time together this afternoon. I was excited to have this opportunity again to speak to you guys, and we're just going to talk about some OSHA things and what's required documentation for you as managers. What do you have to keep your employees safe during their working hours? So I hope that everybody can see my slides and hear my voice. If you cannot, let me know, and Erin and I can make some adjustments possibly. So again, let's get started here this afternoon. Again, my name is Ray. I just want to let everybody know I am an employee of Total Medical Compliance, where we do compliance consulting for medical and dental offices. My background, as Erin was saying, is dental. However, I've been a consultant in the medical field also since 2008 is when I switched over from dental to consulting. Today, any reference to a commercial products for example purposes only, I probably won't do that, but if I do, it does not reflect endorsement. Anytime I ever speak, I always say, as far as I'm concerned, it does not matter to me what product you use, as long as you follow manufacturer's instructions for use. Also, this is not intended for legal advice, and no recording, of course, of this seminar today is allowed. We will talk a little bit about the bloodborne pathogen standard. We're going to talk about the globally harmonized system and what is required documentation wise for you to comply with the bloodborne pathogen standard. Most of you here today are probably those managers, and that's what you need to know. What do I got to do to keep everybody safe? And then also, what do I have to have in place in case OSHA ever walked into my facility? I was just looking to see. But that said, first of all, I didn't say this as my disclaimer, but whatever I say about COVID will probably change before the end of the webinar today. And we're not going to talk a whole lot about COVID this morning. Most people are just almost borderline and on tired of it. Erin and I were just talking about that a little bit. But I do want to show you a couple of pictures from the map of the United States, and then I'll show you each state where my audience is today: Pennsylvania, West Virginia, and Virginia. As we know, the CDC put out community transmission rates, and then we have community levels. And of course, the community transmission rates apply to the healthcare world. All healthcare facilities, as community transmission rates, CDC says that we should follow their recommendations for those healthcare facilities. So on this map of the United States, we have blue areas, yellow, orange, and red. All of the blue areas are low community transmission risk. Yellow is moderate, orange is substantial, and red is high. Community transmission rates are based on how many COVID tests are taking place in your communities and what the percent positive is. So that's where the community transmission rates come from. And then we have community levels, and they are either low, medium, or high. Community levels, per the CDC, talks about or is based on what is going on in our hospital settings. So how many people are in the hospital, how sick we are, what's going on in ICU. Also, and the community levels are based towards the general public. They are not for healthcare facilities to follow. However, I do think it's important that we know where those community levels are at across our states. So if you notice your states there for Virginia, West Virginia, and Pennsylvania, here's the Pennsylvania community levels. So if you were in Pennsylvania and you find your county, a lot of y'all are still low community levels. However, you do have some medium and high community level counties. And then Virginia levels are the same way. You have low and medium levels that are taking place. And then I won't leave West Virginia out either, low to medium community levels. So that's probably still, that's a good thing that maybe our hospital systems are not so overloaded at this time. And we don't have a lot of people in the hospitals for COVID at this moment. However, when we take another look and we look at our community transmission rates, if you remember from the very first slide, anywhere you see blue is low, not blue. Blue is low community transmission rates. Yellow is moderate, orange is substantial, and red is high. And so Pennsylvania, your numbers are for community transmission rates are creeping back up, along with the rest of the United States. Here's Virginia. And then, of course, I won't leave West Virginia out either. And there you go. West Virginia, you still at least have one county that has low community transmission risk. Most of the CDC guidelines are all based on community transmission rates or of moderate, substantial to high. So as long as you're in substantial to high, you have that chance of seeing an asymptomatic or pre-symptomatic COVID person in your facilities. So just wanted to throw those out there for you. And if you want to know where I got these from, of course, it was from CDC's website, which is www.cdc.gov. Community levels, if you just start clicking on links, maybe some of you have already done that. If you click on the links, it'll take you to not only community levels, but the community transmission rates also. And that is pretty much all I'm going to say about COVID today, just to let you know what's going on in your communities. And the CDC still has recommendations for the healthcare facilities, and they haven't changed, by the way. A lot of people, when most of our states were in low to moderate, we're dropping masks for their facilities, but CDC guidelines or recommendations for healthcare facilities has not changed. So we should still be having our patients wear their mask, and of course our employees should also be masking up, especially in patient care areas. Hand hygiene as part of COVID, and even in the standard precaution, is an element of standard precaution in your facilities. CDC's always said the single most critical measure for reducing transmitting organisms to each other and to our patients is hand hygiene. And so we should be using soap and water for 20 seconds if your hands are visibly soiled or dirty. After you go to the restroom, really shouldn't have to say that one, before you eat, sorry. And then if you have a patient that has the norovirus or you have a patient that you suspect has C. difficile, or if you're cleaning up stool, you should be using soap and water. All other times, CDC says we can use those alcohol-based hand rubs for 15 seconds. Employers do have to supply hand washing facilities to their employees, by the way. Not that you didn't already know that. I did want to mention before we start really getting into OSHA, Virginia, you are the only OSHA approved state plan out of our territories this morning. Pennsylvania and West Virginia go by federal OSHA guidelines, but Virginia, you do operate on an OSHA approved state plan. And so I just threw that up there for your information, but you can get telephone numbers or addresses of any of your OSHA offices for your state just by going to OSHA.gov. So OSHA.gov for those of you that I didn't have this information up, Pennsylvania and West Virginia. Again, you go by the federal plan. So let's talk a little bit about what is required for employers to supply to their employees. And I know as medical managers, this is where you folks would be most interested, I'm sure, to know what I've got to have. Not only do you want to keep your employees safe, but you're probably in charge of some of the documentation and keeping it up to speed, I guess is a good way to put it this Friday afternoon. So the bloodborne pathogen standard was enacted in 1991, and it was written to the employers of what they must do to keep the employees safe. So it's a rule that employers have to follow. If an OSHA inspector came into your facility, the only thing that OSHA inspectors look at are employee safety issues. So the bloodborne pathogen standard covers what employers must do, the requirements for their employees to be kept safe. And again, when you have your OSHA training for your employees, by the way, you have to have a copy of the bloodborne pathogen standard available during that training. And that copy can be online, by the way. You can get it online at OSHA.gov and just type in bloodborne pathogen standard, and there you go. So you do have to have a copy for that. Inside the bloodborne pathogen standard, it discusses 3 bloodborne pathogens: HIV, hepatitis B, and hepatitis C. And of course, if I was on site with you in your facility, I would tell you that all of my trainings are geared towards preventing an exposure to one of these bloodborne pathogens and what are the best ways to protect your employees from an exposure to that bloodborne pathogen. So bloodborne pathogens, we know, are located in the blood. It's a harmful bacteria or virus, and it can be transferred by an exposure. Keeping in mind that that exposure is not only a needle stick or sharps injury, but it also could be a blood or other potentially infectious body material splash to the eyes, nose, mouth, or non-intact skin. Some fast facts are a little bit on HIV, Hep B, and Hep C. And again, I know you are managers, but I'm thinking maybe some of you might be nurse managers out there, and this would count for your bloodborne pathogen training, by the way, annually, if you wanted to count it and go back to your employees and give them the same type training. So a little bit about HIV, hepatitis B, and C. HIV, we know, is the virus that causes AIDS. Early symptoms resemble those of the flu or no symptoms at all. You only have a 0.23% chance of acquiring HIV with a known HIV needle stick. There is no vaccinations for HIV, but there are treatments that allow for the virus to become undetectable in the blood. And once that virus is undetectable, the HIV patient can no longer transmit HIV. So a very low chance of acquiring HIV, and the reason being is HIV does not live out the body a long amount of time. And then we have hepatitis B and C. You can have joint pain, abdominal pain, dark urine, clay color bowel movements. Of course, fever, nausea, diarrhea, yellowing of the skin, or yellowing of the whites of the eyes could all be symptoms of hepatitis B and C. If your employee has not had the hepatitis B vaccinations, or you have an employee who did not respond to the hepatitis B vaccinations, their risk of acquiring hepatitis B with a known needle stick could go up to 30% chance. However, since the vaccine's been made available, there's been a 95% occupational transmission decline. Per the CDC, if someone has had their hepatitis B vaccinations, they've got a titer or that post-screening that states that they have the antibodies, then per CDC, they have a lifetime or long-term immunity. There are no longer booster shots for Hep B, and you don't have to repeat a titer. For hepatitis C, you have a 0.2% chance of acquiring hepatitis C with that known needle stick. There is no vaccination for hepatitis C. However, there are some cures that are working very well for hepatitis C. It has been reported, hepatitis C, that is, has been reported with a blood splash to the eyes. So you want to make sure that that you or your employees are wearing eyewear with any procedures that create splash and splatter of blood. CDC changed the testing recommendation, by the way, for hepatitis C, and that recommendation is now for those patients that are 18 years of age or older, and everyone during each pregnancy should also be tested for hepatitis C. We'll say hepatitis C can live in dried blood on a dry surface for 4 days or longer, and hepatitis B can live 7 days or longer. So that gives you a little bit of idea about HIV, Hep B, and Hep C that's found in your bloodborne pathogen standard. So if you are a manager in your facility, this is one thing that is required by OSHA to be offered your hepatitis B vaccinations. It should be offered to all your employees that have an occupational exposure risk to blood, and it should be offered within 10 days they have their working assignment and after they are trained. So again, this is an OSHA requirement that you offer the Hep B vaccination. If the employee does not want to get the hepatitis B vaccination, then they would sign a declination statement. I promise, if an OSHA inspector ever walks in your facility, no matter where you are, they will check this. That I had an office in, down from you guys in Fayetteville, North Carolina, that had an OSHA inspector come in, and he asked the OSHA officer about the hepatitis B vaccination status of those employees, and the officer told the inspector, she said, I know we have the hepatitis B vaccinations for our at-risk employees. However, our office manager is off today, and they are locked in her office in a locked file cabinet, which we're going to talk about medical records, and they do have to be kept confidential. The OSHA inspector looked at the OSHA officer and said, well, that's okay. I'm going to be here all day. You got 2 hours to produce that to me. So she had to call the manager to come in on her day off to get access to hepatitis B vaccination status. If not, they would have been cited for that. So if you are a manager, most of you probably are in your facilities, and you are the only one with access to this, if you are out on vacation or sick leave or anything of that nature, I would ensure that somebody else, one other person at least, could get to that documentation, because if an OSHA inspector shows up, they will ask for that. Again, that's I promise on that one. How about that? But make sure you have offered that. So on file, per the bloodborne pathogen standard, you either need to have documentation of the vaccination series plus that titer post-screening stating they converted, or you need to have the employee can say, well, I had my hepatitis B vaccinations years ago. Here's my documentation. You can keep that documentation on file, or they can sign a declination. But you have to show OSHA if they walk in that you've offered that at no charge. And again, employees, if they would like, they could decline that. All that information from hepatitis B could be found at the CDC website, again, www.cdc.gov. So standard precautions, we know that we're going to treat all of our patients the same regardless of their infection status. We follow those standard precautions, the elements of standard precautions. And I'm telling you this because inside of an exposure control plan that we're going to talk about in just a moment covers some of this in standard precautions, that you're offering hand washing facilities for your employees. Employers are responsible to provide and maintain personal protective equipment. And then you're going to have up a cover your cough poster and try to get your employees to understand we need to cover our cough. I think we're probably getting better about that since COVID, I hope. And then safe injection practices. We're not going to cover instrument management or environmental services and cleaning and disinfection today, or safe injection practices, but all of these are just elements of that standard precaution. In other words, we're going to do the same thing for everybody. Everybody's treated the same regardless of their infection status. So moving on, what are some requirements of the standard? What do you have to have in your facility? Well, you have to have an exposure control plan. And that exposure control plan does have to be in a written format, and it does have to be annually updated. So at least annually, someone needs to ensure that that exposure control plan has not changed. You do have to offer the hepatitis B vaccinations at no cost to the employees that have an occupational exposure risk to blood. And then, of course, part of the standard would be, how do you communicate hazards to your employees? What types of labels and signs do you have? And then personal protective equipment has to be supplied and maintained by the employer. So it's supplied and maintained to employees by the employer. And then work practice controls, engineering controls, and how do you annually review those in your facilities? Post-exposure follow-up and then record keeping we're going to talk about, but post-exposure follow-up per OSHA, again, has to be offered at no charge to the employees after an exposure risk. So an exposure control plan, what goes inside that exposure control plan? Well, first of all, like I said earlier, you do have to have a written plan. And the exposure control plan tells how the employer is going to provide all this protection for their employees. Again, it has to be updated annually. Exposure determination of employees. Who has an exposure risk? And most of your facilities, it's going to be nurses, it's going to be physicians, of course, maybe mid-levels, CNAs, all of those. Who has that exposure determination? And then engineering controls we will talk about, but that's a piece of a device or an equipment that helps eliminate or removes the hazard from the workplace. Work practice controls or worker behaviors. So you would talk about these things inside that exposure control plan, like work practice controls, no eating, drinking, applying lipstick, chapstick, mascara in a place that has a potential for an exposure. Personal protective equipment, gloves, masks, eyewear, lab jackets, lab coats, depending on where you are. You may even supply surgical caps or booties if you're in a surgery center. And then post-exposure follow-up, what should your employee do if they have an exposure? What is your protocol in your facility? A lot of medical facilities handle those post-exposures on site, and you can do that, or you can outsource that. This exposure control plan has to be accessible to your employees, and they should have a copy if they want it. I don't know that any employee will ask you for that, but if they do, you have to give them a copy of the exposure control plan. Again, it has to be updated annually, and that means put a date on it. When I say update something, that means, oh yeah, I'm going to read it and I'm not going to date it. I find that in a lot of my facilities when I'm go in, they'll say, oh yeah, we did that. And I'm like, when did you do this? And they won't have a date on it. So make sure it's January 1st, 2022 or 2023, whenever. Make sure you got that date on it. And that date should reflect any changes. And then annually, you have to consider and implement possibly or evaluate a safer medical device. So an exposure control plan, do you have it? Do you know where it is? And how has it been annually updated? Employee trainings. So all your employees that have an occupational exposure risk to blood have to have bloodborne pathogen standard annually. So in those employee training records, and by the way, most states, those inspectors, when they go in, they expect all of your employees to be trained somewhat the same way. And I say that because some people say, oh, well, I went to a conference and these employees over here, they went to, they did a webinar or whatever. So as long as it's somewhat similar, you have to have that. I know like in North Carolina, they will cite you if you don't provide that training the same type way for all employees. So on your employee training records, sorry, not medical records yet, we're going to get there. But in training records, you need to have the date that the training session took place, contents or a summary of the session. So what was discussed in the training, and then names and job titles of attendees, you know, who's a doctor, who's an RN, who's a CNA, and then who performed the training or conducted that training for you and what were their qualifications. And all employee training records should be retained for 3 years per OSHA. So 3 years per OSHA. And medical records. So all employees that have are at a risk for bloodborne pathogen exposure should have a medical record. And it is a confidential medical record. In other words, it's not kept if you're in private practice, it's not kept in that medical record. It's something separate. It's a medical record for employees, not a medical record for patients. So you're going to have your employee's name and social security number, a copy of the hepatitis B vaccination status, and then any results of examinations or testing or follow-up procedures that occur after a post-exposure or an exposure incident. All that results and paperwork go inside the employee medical record. Employer's copy of a healthcare professional's written opinion, which is provided during an exposure incident. All incident reports are there, copy of information provided to the healthcare provider. A lot of times facilities keep vaccination records in these employee medical records. Also, the CDC does say that they recommend that all healthcare professionals stay up to date on all of their vaccinations, and that includes things like your MMR and your tetanus, flu vaccination. If you have a flu vaccination and offer it, all that should go inside that employee medical record. And everybody loves that last little statement where it's retained for the duration of the employment, and then add 30 years. OSHA is a 30-year entity on some things, and this is one thing you should keep: 30 years past their final employment date. Any questions on medical records or training records or exposure control plan, hepatitis B that we've discussed so far?
We don't have any at the moment, Renee.
All right, thank you. I figured you would stop me, but I thought I would just ask to make sure. You can ask questions as we go, or I'm going to try to get through a few minutes early, and you can ask questions at the end if you would like. So personal protective equipment is based on the potential exposure risk of your practice. Gloves, mask, eyewear, lab jackets, lab coats, all of these are offered and supplied and maintained by the employer. So personal protective equipment, employees cannot bring personal protective equipment from home to use. It should be supplied and maintained by the employer. And of course, personal protective equipment is to cover skin and or street clothes of your employee. So again, we have personal protective equipment. We're going to train everyone on the initial assignment, and then you review that as part of the exposure control plan on an annual basis. Personal protective equipment must be accessible, properly cleaned, laundered, repaired, and disposed of at no cost to the employees, and it should be removed when you leave the area of contamination or your clinical areas. Gloves should be worn if you have unexpected contact with blood, saliva, or mucous membranes, or when you're touching contaminated surfaces. I'm sorry, I stopped for a minute. What if your specialty that does not have blood, do you still have to offer the hepatitis B vaccinations? If no one has, if you don't, it's like strictly administrative, so no one in your office draws blood, gives injections, cleans rooms where there's a potential for blood, then you may not have to offer the hepatitis B vaccination series, just depending on that healthcare, what you're doing in your facility. That's a great question, by the way. Thank you for asking that. But that is correct. If you don't have any occupational exposure risk to blood, not cleaning up exam rooms, not cleaning up bathrooms or drawing blood, giving injection, or bathrooms only if there's blood in there, by the way, or any kind of equipment. So great question. Thank you for asking, by the way. So gloves are to be worn when you touch contaminated surfaces, or you come in contact with any, not only blood, but other potentially infectious body materials, which could be saliva or mucous membranes. You should dispose your gloves after each use. So a new pair for each patient. They shouldn't be washed for reuse. If they become cracked, torn, or compromised in any way, you should discard them and get you a new pair. And then heavy duty utility gloves. Your facilities may not need heavy duty utility gloves, but if you are handling contaminated sharps where you are doing instrument processing in your facility, CDC and OSHA say that we should wear utility gloves when you're handling those contaminated reusable sharps. They should be puncture resistant, chemical resistant. You can wash them, you can autoclave some of them, you can surface disinfect them. Also, some corrosive chemicals, which we are going to talk about in just a few minutes. Corrosive chemicals, some of those will say you need to have on utility gloves when you are handling that. So utility gloves may be needed in your facility as part of personal protective equipment. Your gowns or lab coats, again, can be reusable or disposable, but the employer is responsible, again, to launder that contaminated reusable gowns or protective clothing. And of course, disposable gowns should also be disposed of by the employer. You should change your gowns at least daily or as soon as it becomes visibly soiled. Eye protection, if you're doing any procedures that create splash and splatter, not only of blood, but other potentially infectious body materials, you should have on eye protection, goggles, or a face shield, and you should clean and disinfect those if they're visibly soiled and after each use. Masks when are required when you are, if you're seeing any patients that are COVID positive, suspected or confirmed COVID-19, you should be wearing an N95 respirator, or if you're doing any splash and splatter procedures, aerosol generating procedures, that to those patients in those areas where you have substantial to high community transmission rates. If you remember when I was talking about that earlier, some of the changes with the CDC guidelines for healthcare was basically around respiration. So N95 should be worn if you are seeing suspected or confirmed COVID-19 patients, and if you're doing any aerosols generating procedures when you are in those substantial to high community transmission areas, risk areas. If you're in low to moderate, you would not need to wear the N95s. You could wear level 3 surgical masks. So your mask should be changed between patients, and then of course if they become moist during any long procedures or surgical procedures, you would change those possibly. If you're utilizing respirators in your facility because you're seeing suspected or confirmed COVID patients, or you're doing aerosol generating procedures in an area of substantial to high community transmission rates, you also have to have a written respiratory protection plan, and that is required by OSHA, by the way. And as part of that written respiratory protection plan, that includes a medical evaluation and fit testing for your employees. So I wanted just to tell you managers about that also, that you do have to have a written respiratory protection plan if you're using respirators, N95s or higher. So work practice controls, we talked about that as an element of standard precaution, and that is inside, should be inside your exposure control plan. So work practice controls are worker behaviors, things your employees know not to do or stay away from when they have an exposure risk to bloodborne pathogens. So you would not eat or drink or apply lipstick, chapstick, mascara in an area where there's a potential for an exposure to blood, such as in a central sterilization area or a lab. I've gone into labs in medical facilities before, and they'll be eating in there, drinking in there. All that should be saved for the break room. You should safely transport your instruments. That slide's right, by the way, the one on the upper left on the top row with the container with the biohazard sticker, that one's right. I don't know if it lets you see that or not. And this one's right on the lower right-hand corner where she is scrubbing instruments. If you're going to scrub, you should use a long-handled scrub brush. All personal protective equipment, if you notice, she has on utility gloves and she's scrubbing down into the sink. So that's correct. Those two slides are correct and all the other pictures are wrong. I went into an office last year and I didn't really chuckle then, but I chuckled afterwards. Not chuckled because I thought it was funny, but just chuckled because I just was kind of disbelieving for me. But I opened up a cabinet in a central sterilization area where the autoclave was, and they had a big ultrasonic cleaner in that central sterilization area. And I opened a cabinet underneath the central sterilization area, and well, there sat a donut with a bite out of the donut, and it was on a paper towel. And the paper towel was on top of the open Coke can. And I think I literally went, oh, and the OSHA officer said, oh, I meant to move that before you came. That's mine. And I was like, that does not make me feel better. So there should not be eating or drinking in those central sterilization areas. So no donuts. No donuts, keep those for the break room. Sharps containers, once it hits that do not overfill line, not only is that an exposure risk for your employees, but OSHA would cite your office on that. By the way, OSHA does cite for overfilled sharps containers, so discard of those. If you're gonna reprocess contaminated, reusable sharps like instruments, that's where, as part of the bloodborne pathogen standard, that it says it needs to be placed in containers that are leak proof on the sides and the bottoms. And so that's why this slide on that the top row on the upper left is correct. You can buy your container from the Dollar General. That's what I tell everybody. Pencil boxes work great. But anyway, contaminated reusable sharps to transport them from the area of use to your central sterilization area should be in a closed container, leak-proof sides and bottom. And then we have engineering controls, which is a piece of equipment or a device that helps eliminate or remove the hazard from the workplace. As part of your exposure control plan, you talk about work practice and engineering controls. There is something called the Needle Stick Safety and Prevention Act, and it states that if there is an engineering or a safety device, engineering device on the market for whatever sharps you're utilizing in your facility, then you should utilize that safety device. If you're not doing that, then you need to evaluate safety devices. Regardless, OSHA requires, so managers, here you go, is another requirement by OSHA, that once a year you need to get input from your clinical team members on any work practice or engineering controls for your facility. And you would document that once a year, annually, of course, with a date again, that you did get input or feedback from your clinical team members on any work practice and engineering controls. And all of these here are examples of engineering controls, which are safety devices on the equipment. And so that's just some examples that you may be interested in trying to evaluate or get for your team members to evaluate once a year. at least. Most medical offices use safety devices. I have to tell you that. All right, so after you evaluate your work practice and engineering controls every year, we're going to move on to what happens if we have an exposure. If you have an exposure incident to blood or other potentially infectious body material, splashes to the eyes, nose, mouth. Again, we got a splash to the non-intact skin or a stick with a needle stick or a sharps injury. What is your plan? And managers, I would say that this is one thing that you should have in place before you need it. So do you have a post-exposure protocol? And that is also part of that exposure control plan that has to be annually or updated per OSHA. So if you have an employee with an exposure, the first thing they're going to do is clean it and then report it now, immediately. And stress that to your employees. You don't want your employee to wait 2 days or 2 weeks, or like I had an office a year ago that called me, and one of their employees had waited 2 months and then decided she wanted to report this exposure because of some blood work she had done. So employees, you have to report it immediately. And then OSHA requires, again, that the employer offer a post-exposure evaluation and counseling as part of that evaluation. A lot of people say, oh, we'll just send them over across the street to LabCorp or LabQuest. That's great. But who is going to provide counseling for your exposed employee? So they clean it, they report it immediately. OSHA requires that the employer offer all exposed employees that post-exposure evaluation and counseling. The worker can decline the process, and they would need to sign a declination if they decline the process, or they would go get tested for HIV, Hep C, and or Hep B, depending on hepatitis B status of your exposed employee. All of these steps and paperwork is kept inside that employee medical record that we talked about earlier on. Any questions thus far? Everybody's good so far? Still? Yeah, okay. So regulated waste, and I will emphasize this, OSHA defines what regulated waste is for us. And all of this that's on the slide, it fits their definition. So it's any pathological, microbiological waste that contains blood. OPIM is other potentially infectious material. So liquid or semi-liquid blood, contaminated items that would release blood or OPIM, items that are caked with it, or contaminated sharps. So for inside your sharps containers should be your needles and your blades. This is the part that I was going to say that changes sometimes. So OSHA defines what regulated waste is for us, how you dispose of it, and sometimes what you put inside a regulated waste bag or sharps container can be state by state, or it is state by state on how to dispose of it. But what goes in it can be state by state also. Some states, like North Carolina, is county by county of what they can do or how they dispose of their waste. So today I would encourage all of you, if you don't already know your state's guidelines, to go to your state's website and find out what they would like you to do with regulated waste, unless you're already having it picked up, and then you're fine if you are, by the way, and how picky your state is about what goes into a regulated waste bag or sharps containers. And then we have hazard communication, and this is going to finish us up with our requirements or with our objectives today. But hazard communication, OSHA requires that you have a hazard communication plan that is written, and of course you've probably already figured out that it's got to be annually updated, or at least annually looked at. However, I feel like hazard communication is always ongoing, because you may get new drugs into your facility, or new chemicals may be coming in. This was a practice that actually was destroyed by compressed gas tanks. So OSHA's hazard communication states that employees have a right to know the chemicals they come in contact with, but they aligned with the globally harmonized system, or the GHS system, in 2016, stating not only do employees have a right to know the chemicals, they should also have a right to understand those chemicals. So that's when things started changing a little bit for us, where we used to collect what's called material safety data sheets. Now they're called safety data sheets. And on the safety data sheets, you'll see a pictogram, a little symbol. You'll see a signal word, which will be danger, warning, and danger is the more severe hazard. Then you've got a hazard statement and a precautionary statement on your safety data sheets. I have found in my medical facilities, when I go inside to do the mock audits for them, a lot of times the nurses or your lab may keep up with your safety data sheets. However, I think managers should be aware of hey, you've got to have a written hazard communication plan, and making sure that it is kept up to date. Not that you can't delegate it and let others help you with that. But again, you need to be aware that, hey, this is something we've got to have if an OSHA inspector walked in, or if an employee has an exposure to chemicals, what do I do? So that's why I'm covering hazard communication today with you. So the pictograms from the globally harmonized system, or the GHS, we have physical hazards, which are on the top row, and health hazards on the bottom, and environmental hazard is in that lower right-hand corner. And I won't go through all the pictograms with you, but keep in mind that of course, skull and crossbones is a severe health hazard, possibly death. Star on the chest, it's an aspiration hazard, but it also could be a carcinogen if you see that on a chemical or a medicine. And then we have a corrosive symbol. Bleach is your most common corrosive. It's corrosive not only to metal, but also to skins. Your most common ones are going to be your exclamation point, though, and your flames, meaning flammable. And not only a skin irritation for that exclamation point, but it could be an allergy type irritation, like an itchy throat or runny eyes. On your safety data sheets, if one of your employees has an exposure to your safety data sheet, what do you do? So sections 2, 4, 6, 8, who do we appreciate? 2, 4, 6, 8, who do we appreciate? 2 is hazard identification. 4 is first aid. Section 6 tells you how to clean up that chemical, and Section 8 tells you what personal protective equipment you should have on when you're handling that chemical. I'll tell you that I had an employee not long ago that had a splash from a chemical to her eyes. So if that happens in your facility, someone would need to look up the safety data sheet and figure out, what do you do? More than likely go to your eye wash station and flush it out. But what are the first aid measures? Employees have to know how to access their safety data sheets in your facility and where they are located. Had an office that was inspected by an OSHA inspector, and they did ask the different employees. They also interviewed different employees. Like if you have an OSHA officer in your facility, OSHA inspectors will interview others. And this is one of the things they usually ask those employees: where are your safety data sheets? Can you access them? And a lot of times I'll go into facilities and I'll even ask employees, where are your safety data sheets? And they'll say, oh, they're online. McKesson has them. They're all online. And I'm like, do you know how to get on McKesson's website? Again, you can keep them electronically or hard copy, but if they're electronic, everybody needs to know how to access them and have access to them. OSHA requires immediately access to safety data sheets for employees. And then an eye wash station. If you are having any corrosive materials or chemicals in your facility, you do need to have an eye wash station that is a suitable facility for drenching and flushing of the eye or the body area. And it needs to be immediate use for the employees within 10 seconds of the hazard, 15 seconds of the hazard, not upstairs through the elevator or wherever down the hall. Immediate access. And then they have to have, you should weekly flush that out. And you need to have a certain flush capacity. Water temperature should be tepid, and a single step activation is a suitable eye wash station per OSHA if you have corrosives in your facility. Any chemical out of its original container into a secondary container does need to have a secondary chemical ID label on it, with the chemical's name and what is the hazard precautions and your first aid measures or personal protective equipment also. So any chemical out of its original container into that secondary container does need to have a chemical ID label on it. And then fire response, which is the last thing we're going to talk about today. OSHA gives employers 3 options for a fire emergency. Option number 1, all employees evacuate, of course, taking their patients with them. Option number 2, some employees stay and fight the fire. All others could evacuate. Or option 3, all employees stay and fight the fire. Everybody else, nobody evacuates. How about that? So option 1, 2, or 3, total medical compliance. We always encourage option number 1, which is everyone evacuates, nobody stays and fights the fire. If your employer chooses option 2 or 3, where some employees stay or all employees stay to fight the fire, then your employer has to provide annual hands-on training to use the fire extinguishers. Again, the employer, if they choose option 2 or 3, annual hands-on training. In other words, if you have not trained your employees to fight the fire or have not approved them to stay and fight the fire, they can't fight the fire and they cannot utilize the fire extinguishers. So just be aware of that. So what's your fire response? I always recommend an annual fire drill to make sure everybody knows what their duties are, whether they evacuate or not, and where your meeting place is. I had a big facility, medical facility up in the upstate of South Carolina. And after I went in and did their training, a couple of weeks went by and the safety officer emailed me and she said, Renee, we did a fire drill and, well, we failed miserably. And I sent her an email back. I said, what do you mean you failed your fire drill? And she came back and she said, well, let's just say that I had people in the parking garage. I had people out front. I had people that stayed and didn't leave. And I had some people that stayed and tried to use the fire extinguishers when they were not approved to do that. So a fire drill will help eliminate that. Where are you going to meet outside? How do you know who was in your building and who got out safely? And that means who was in your building. Was your drug reps in there or your sales reps in there? Who was there? So that when you evacuate, you can be accountable for everyone. Other things to keep in mind with fire emergency: power strips are for low power loads only, not high powered loads. So things like electric heaters, space heaters, microwaves, toaster ovens, coffee pots, electric throws should not be in a power strip. They should be plugged directly into the. If anyone needs any help with their OSHA or HIPAA or infection control needs, please don't hesitate to reach out to us.
I thank you for your time, Renee, and for your speed talking. That was wonderful. I thank you, and I thank all of our attendees today. Again, the webinar was hosted officially by the Pennsylvania MGMA, but our program monthly is brought to you from West Virginia, and the Pennsylvania MGMAs collaboratively. So I thank all of everyone for participating, and I thank Renee and Total Medical Compliance for joining us today. I don't see any questions, so I thank everyone for joining us. I hope everyone has a good weekend. Stay dry if you can, and enjoy the weekend. And we will see you again next month.